Good morning, respected Emeritus Chairperson, sir, respected Vice Chancellor, sir, respected professors, seniors, and my dear colleagues. Today, we are here to discuss the combined clinical rounds by the Department of Obstetrics and Gynaecology. Prior to starting the case discussion, I would request Dr. Swati Garg ma'am, Professor and Head of the Department of Obs and Gynae, to kindly come and speak a few words about the department.
Good morning, everyone. I am giving an overview of the Department of Obstetrics and Gynaecology. The department was established in the year 2000 with the inception of the institute. The undergraduate teaching started in 2001 with 100 seats and post-graduation in 2009 with 3 seats, steadily increasing with time to the present 13 postgraduate seats per year. Our dedicated team of faculty, staff and students work hard to achieve the vision and mission of the department to give excellent and compassionate patient care, effective clinical and educational programs, course in medical education. Only a very few from clinical branches could achieve this. And also keeping ourselves updated with the knowledge. Many of us have completed this AI course in healthcare conducted by NBEMS over a period of 6 months. Intervention radiology facilities frequently being used not only for image-guided biopsies and aspirations, but also for the management of conditions like AUV due to fibroids and AV malformations. Important use nowadays is in case of placenta accreta syndrome, where we could avoid hysterectomies in young patients by doing bilateral uterine artery embolization. We have dedicated division of fetal medicine, doing scans and procedures for diagnosis of fetal structural anomalies and chromosomal disorders. Therapeutic procedures like amniocentesis, CVS, fetal reduction, fetal therapy for arrhythmias are also being done. More than 30 intrauterine fetal transfusions have already been done for fetal anemia due to RS sensitization and other conditions. Another division of our department is Center for Advanced Gynae-Endoscopic Surgeries, doing all laparoscopic, hysteroscopic and robotic surgeries. Today's case was managed in this unit, and I request Dr. Nata to speak about the work done in cages. Thank you.
Adarniya Chairman Sahab, Emeritus Chairman and सम्मानित अधिकारी वृंद, मेरे सहकर्मियों, जय हिंद, सुप्रभातम. So I am here to beat our own drums. So अपने खुद मियाँ मीठू बनने की कोशिश कर रहा हूँ. So we are running a 3 months fellowship program in advanced gynae hysteroscopy and laparoscopy, and now added robotics. So till now we have trained, given fellowship to 58 post-MS and practicing gynecology. Out of them, 18 are doing advanced work in their respective places. 40 are doing all gold standard indications.
Good morning, dignitaries, professors, seniors, and my dear colleagues. My name is Dr. Navya Jain, postgraduate resident from Obs and Gynae department. Today we are discussing the case of a 38-year-old female with lower abdominal pain and history of multiple pelvic surgeries. Mrs. A, a 38-year-old female, para 2 living 2, resident of Sikrai, Rajasthan, is a government teacher by occupation and presented to Mahatma Gandhi OPD with complaints of heaviness and pain in lower abdomen for the last 6 months. She was asymptomatic 6 months prior and then started developing heaviness and lower abdominal pain, which was insidious in onset, dull aching, not radiating to any other parts, intermittent in nature with no diurnal variation. The pain was relieved on taking analgesics, and she could not identify any aggravating factors. She did not have any history of nausea or vomiting, no bladder or bowel disturbances, no abnormal discharge per vaginum, no fever, loss of appetite or weight loss. She had undergone hysterectomy for abnormal uterine bleeding in the year 2025, prior to which she had complaints of heavy menstrual bleeding, which were lasting to 5 to 6 days, every 10 to 20 days, along with passage of clots. Obstetric history: she was para 2 living 2. Both her children delivered via lower segment cesarean section. Last childbirth was 10 years back. Past history. She did not have any significant medical illness. However, her surgical history was noteworthy, with 2 lower segment cesarean section and 1 laparoscopic hysterectomy with bilateral salpingectomy in the year 2025. Post-operative period was uneventful. Histopathology report was unavailable to us. So outside ESEI in Jaipur. ESEI, yes. ESI. The patient was told to have few adhesions post-operatively, but it was just a verbal report. There was no family history of diabetes, hypertension, or any gynecological malignancies. Her personal history was unremarkable. General physical examination, the patient was conscious, cooperative, oriented to time, place, and person, hemodynamically stable, with no signs of pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema. Systemic examination was unremarkable. For abdominal examination, on inspection, the abdomen was not distended. There were previous surgical scar sites present. On palpation, there was no superficial or deep tenderness, no organomegaly or any other palpable lump. On percussion, there was tympanic note present and bowel sounds were present on auscultation. Gynecological examination. Her normal genitalia, external genitalia was normal, Per speculum examination, vaginal mucosa was normal, the vault was healthy, healed and held well. A wall smear was taken. Bimanual per vaginum examination revealed a cystic mass which was felt in the left side of the pelvis, approximately 6 into 7 centimeters. The mass had restricted mobility and was non-tender in nature. There were no abnormalities detected on the per-rectal examination. To summarize the case so far, we have a 38-year-old female, para 2 living 2, who presented with heaviness and pain in lower abdomen for the last 6 months, with previous to lower segment cesarean section and a laparoscopic hysterectomy with bilateral salpingectomy. Our clinically significant findings were, on bimanual pelvic examination, a left-sided cystic mass of 6 into 7 centimeter. At this stage, based on the patient's history and clinical examination, I would request the audience to...
Navya beta, ये बताओ कि इतनी young age में 38 years old female,
Yes, sir.
having hysterectomy and salpingectomy, is it justified? Have you gone into the detail with the patient or patient attendant? This is a serious issue.
Yes, sir.
And that too in Jaipur.
Yes, sir. So the point that you have raised is completely valid, and usually in Mahatma Gandhi, the practice that we have learned so far, we do not conduct hysterectomies for patients below 40 years of age. I have not seen any, and we have not done any in our department so far. We usually try to provide medical management to these patients, but this case was done outside, and we did not have the entire report of exactly why.
Can you highlight this issue? Yes.
So nowadays the government have become very strict, and in fact we are documenting that if any hysterectomy to be done in below 40 years of age, it has to be certified, not certified, it has to be prescribed by at least 2 physicians or 2 gynecologists, and a board should be there, I mean at least a few doctors should be there to say that yes, in such cases the hysterectomy is required. Like you can say early malignancies. Of course, it is indicated, but in abnormal uterine bleeding, it is also there. So in practice, what we have seen that people are not offering the uterine conservative surgeries to the patients, and this is what we are seeing, that the patient getting operated even at the age of 28, 25, and up to any extent. This is what we have seen. Is near to Haryana, sir. हाँ सर, बांदीकुई से आगे जाके जो आता है, correct sir. Correct sir, yes. But it was in ASI.
Hello.
So, sir, even we have a very stringent protocol in our हाँ sir, ovary छोड़ दी थी. And in fact, when we are discussing with our MS that if any patient we need to do before 40, what is the protocol? And they have guided us for this. नहीं sir, salpingectomy. which is an opportunistic removal of the fallopian tube.
Yeah,
Hello.
For my knowledge, in a benign condition, hysterectomy okay, but what is the indication of salpingectomy alone?
Yes,
With
yes, sir.
hysterectomy?
This is a proven this thing that if the tubes are kept, then that increases chances of ovarian malignancy. So now this is a protocol that whenever we do hysterectomy in this age, then we should remove tubes, salpinges. And another fact which I want to highlight here, that not only in the age below 40, even in the menopausal ladies, because we have got a very good histoscopic gadgets and trainings, so we even preserve the uterus of menopausal ladies also with the help of histoscopic polypectomy or guided procedure.
The causes are divided into gynecological and non-gynecological causes. Gynecological being ovarian cyst, tubo-ovarian mass, hydrosalpinx, ovarian or tubal malignancies, parasitic or round ligament fibroid. Non-gynecological causes of encystic collection, peritoneal inclusion cyst, mesenteric cyst, pelvic kidney, retroperitoneal tumor, colitis, cystitis, post-operative adhesions.
बेटा सबसे पहले एडिजन लिखो हाँ?
जी सर।
ये गलत है numbering आपकी।
Your patient has already had bilateral tube removal, so will you think of hydrosalpinx and tubal malignancy in, as a differential diagnosis?
So this differential diagnosis were kept because we did not have the histological report of the patient. It was verbally told to us that the tubes were removed, and plus sometimes we also have tubal remnants which can then have cystic collections and present as a mass, but it's a rare cause. That's why it's in the differential diagnosis at this point. To further characterize the pelvic mass, imaging was essential. The patient already had an ultrasound imaging report from a reputed center in Jaipur, which was suggestive of an adnexal mass. So we requested serum tumor markers for our patient from our center, which were within normal limits. Therefore, we proceeded to request our patient to undergo an MRI. At this point, I would like to invite my colleague, Dr. Apeksha Nagar from Radiology Department, to present and discuss the USG report along with the MRI findings of this patient. Thank you.
Good morning, dignitaries, faculty members and residents. I'm Dr. Apeksha from the Department of Radiodiagnosis, and I'll be discussing this patient under the guidance of Dr. Vineet Mishra, sir. 38-year-old female with complaints of heaviness and pain in lower abdomen since 6 months. She presented to Mahatma Gandhi Hospital with an outside ultrasound report which showed liver, both the kidneys and spleen were normal in size and ecotexture. The uterus was post-hysterectomy status. Right ovary was unremarkable. Left ovary was not separately visualized. However, a cystic lesion measuring 11 into 8 into 7 cm of volume approximately 320 cc is seen in left adnexa with well-defined margin, thin wall and mildly prominent septations. Minimal flow was seen on color Doppler within the lesion. Based on these findings, the lesion was reported as complex left adnexal cystic mass of ovarian origin. Following which, plain MRI pelvis was requested for further evaluation. This is the T2 axial images in which right ovary is normal in appearance with few small follicles within it. There is a lobulated lesion in the midline and left hemipelvis showing thin walls, finely prominent septations, a T2 weighted hypointense component seen within one of the loculation, likely debris or sequelae of previous bleed. There is no obvious soft tissue with intermediate signal and no evidence of restricted diffusion. There is thin stranding, likely adhesion surrounding the cyst, extending up to the adjacent bowel loops and beneath the anterior abdominal wall. Moving to the T2 sagittal images, the lesion is seen in the pelvis above the urinary bladder. Thin adhesions are seen in left pelvis surrounding the cyst, extending up to the small bowel and the urinary bladder. There is also prominence of peritoneal fold. However, there is no signs of bowel dilatation. Cyst is seen closely abutting and displacing the left ureter posterolaterally. Vaginal stem appears to be normal. The urinary bladder is partially distended with mildly thickened and irregular walls. No lymphadenopathy, significant ascites, or omental thickening was noted. Overall, the presence of a large, well-defined, thin-walled cystic lesion with thin internal septation and a T2-weighted hypointense component with surrounding adhesions reaching up to the bowel loops and anterior abdominal wall, abutting and mildly displacing the ureter are suggestive of benign cystic ovarian lesion. Now I would like to request Dr. Maithili to take the discussion further.
Good morning, respected dignitaries, esteemed faculties and my dear colleagues. I am Dr. Maithili, Assistant Professor in the Department of Obst and Gynae. I would further like to proceed with the case. So summarizing my case, this is a 38-year female, para 2 living 2, who presented to our department with lower abdominal pain and heaviness for the last 6 months. She had a significant surgical history of 2 previous lower segment cesarean sections and 1 laparoscopic hysterectomy with bilateral salpingectomy in the year 2025. On bimanual pelvic examination, left-sided cystic pelvic mass of about 6 into 7 centimeter was palpated. MRI demonstrated a benign cystic lesion in the left ovary of size about 10.8 into 8.5 into 7.8 centimeter with tumor markers within the normal limit, suggesting a benign ovarian pathology. So, based on the patient's history, clinical examination and the imaging findings, our provisional diagnosis was a 38-year female, para 2 living 2, post-hysterectomy with left benign cystic ovarian mass with previous to LACS with adhesions. So now coming to the decision-making criteria, the conservative management, the indications for conservative management are only if it is a simple cyst and the CA-125 levels are within the normal range, and size if it is less than 5 centimeter. This is according to the ACG practice guideline, and if the patient is asymptomatic. But in our patient, the indication for surgery was because it was a large multiloculated cyst with size of approximately 10 centimeter with raised CA-125 levels with symptomatic status of persistent pain. So based on the size, complexity and symptoms, surgical excision was the most appropriate management option here. So our surgical plan was a left ovarian cystectomy with the possibility of oophorectomy if ovarian preservation was not feasible. Anticipating bowel adhesions from her previous surgeries, adhesiolysis was planned, and also careful dissection around the bowel and ureter as to reduce or minimize the risk of injury. So then the major challenge in this case was selecting the safest surgical approach. We considered all the 3 options: open surgery, conventional laparoscopy and robotic surgery. Open surgery would have involved greater morbidity, a larger incision and a longer recovery. Conventional laparoscopy, although minimally invasive, has limitations in instrument dexterity and visualization, particularly in the scarred abdomen. So in this case, robotic surgery was the optimal planned modality because it offers significant advantage in a previous operated pelvis. The 3-dimensional magnified vision and wristed instruments allowed safer and more precise adhesiolysis. It offers 7 degrees of freedom of movement, whereas in laparoscopy there are only 4 degrees of freedom of movement offered. So this facilitated meticulous dissection around the critical structures as the bowel, bladder and the ureter, minimizing the risk of injury. Additionally, this minimally invasive approach was expected to provide faster post-operative recovery. So the procedure planned was robot-assisted left ovarian cystectomy with SOS oophorectomy with adhesiolysis planned under general anesthesia. So we carried out pre-op investigations which were within normal range. We got the pre-anesthetic checkup done. Written, informed and valid consent was taken explaining all the risks and consequences and outcome of the surgery. And parallelly, surgical gastroenterology reference was given for intra-op assistance in case of any difficulty. So now planning the entire surgery. The initial abdominal entry is one of the most critical steps in minimally invasive surgery, particularly in this patient, where the risk of bowel and vascular injury significantly increased due to adhesions. So in our patient, we deliberately chose a non-umbilical entry through the Jain's point, which is a safe alternative access site located on the left side of the abdomen, offering lower likelihood of encountering adhesions. So this is the video demonstrating the same. As the adhesions were anticipated, seeing the phalansteal scar and the laparoscopic scar, primary access here was obtained through the direct trocar entry with 5 mm trocar at the Jain's point, which is a point at the level of the umbilicus 2.5 centimeter medial to the ASIS. So here laparoscope was then further inserted, as we can see, to ascertain the safest possible entry. Pneumoperitoneum was attained and further ports were made under vision. This port can also serve as a working robotic port, eliminating need for an additional port. So on initial laparoscopic entry, the pelvis was completely distorted by dense adhesions. Just a second. By dense adhesions, the sigmoid mesocolon was densely adherent to the underlying adnexa and obscuring the left ovarian cyst, and only a small portion of the cyst was visible beneath the bowel loops. So now patient positioning was done in the steep Trendelenburg position with docking of the robotic arms, and we proceeded with the adhesive lysis. So now this is the video, entire video, depicting the complete distortion of the pelvis by the dense bowel adhesion. Severity of the adhesions was assessed. The sigmoid mesocolon was densely adherent to the underlying adnexa, obscuring the left ovarian cyst. This is the right ovarian cyst which appeared normal with corpus luteum. And we can also see there was minimal fluid noted in the POD. So now, further, meticulous adhesive lysis was initiated, first with the flimsy adhesions. The 3D immersive vision of robot guided us where precisely to cut and also to localize the exact margins of the bowel with careful use of energy devices. We can see how the robotic fourth arm is helping us, is stabilizing the bowel loop and the peritoneal fold and helping us give counter traction and traction to facilitate the dissection. So here, since we had already anticipated adhesions earlier, surgical gastroenterology team was informed and they were asked to assist with the bowel adhesions, and we are here doing the colonic mobilization. And further, we can see while performing the lateral pelvic walk dissection, we also encountered periureteric adhesions. So the urology team was also informed and asked to help us in dissecting and delineating and safeguarding the ureter. So now I would like to further call Dr. Akshay Nagwani from the Department of Surgical Gastroenterology to help us guide with the bowel adhesions.
Thank you, Dr. Maithili. Good morning, esteemed faculty members and my dear colleagues. I, Dr. Akshay Nagwani, from the Department of Surgical Gastroenterology, will be discussing the GI surgery perspective of this case under guidance of Dr. Vinay Kumar Mahala. As the preoperative MRI was suggestive of dense adhesions between the adnexal cyst and the adjacent bowel loops. Based on these findings, our GI surgery team was informed before the surgery about the anticipated bowel involvement. During the robotic exploration, the extensive adhesions involving the sigmoid colon and the small bowel were confirmed, and we were called into the operating room to undertake the bowel component of the procedure. As we can see in this video, the dissection begins with the careful identification of the plane between the cyst wall and the sigmoid mesocolon. Gentle traction and the counter traction are applied to expose the natural tissue planes, allowing the meticulous circumferential dissection with minimizing the trauma to the surrounding tissue. The cyst is gradually mobilized from its mesocolic attachments using a combination of a sharp and a blunt dissection. Constant attention is paid to preserve the mesocolic vascular arcade and maintaining the blood supply to the sigmoid colon. Throughout the procedure, the integrity of the bowel of the cyst wall is maintained to prevent the spillage, and complete excision was achieved. The robotic platform provided an excellent 3D magnified visualization and enhanced instrumental dexterity, allowing the precise adhesive lysis in a confined pelvic space. This facilitated the safe preservation of the bowel with minimal tissue trauma and no bowel injury. After complete bowel mobilization and restoration of the normal anatomy, the operative field was handed over to the gynecology team for completion of robotic ovarian cystectomy. Thank you. Now I would like to call Dr. Harsh from Urology to discuss the urological part of it.
Good morning, respected teachers and my fellow students. Myself, Dr. Harsh Patel from Department of Urology. I'll be discussing urological aspects of this case under guidance of Dr. Manish Gupta sir and Dr. Giriraj sir. So we obtained intraoperative reference from Department of Gynaecology regarding a 38-year-old female who had been taken up for left-sided ovarian cystectomy via robotic approach. So they noted dense adhesions around the ureter. So they consulted us for ureterolysis and safeguarding the ureter. So this is the intraoperative view. This is the left side external iliac artery, and this is the ovarian cyst wall, and this is the left side of the ureter. So we begin our dissection by locating the ureter at the most common location of the bifurcation of the common iliac vessels. We located the ureter. We began dissection with combination of blunt and sharp dissection. We dissected off the ureter from distal to the proximal location. In this distal location of the ureter, the blood supply is from the lateral and posterior side within the adventitia of the ureter. So we took careful approach not to injure the adventitia of the ureter, as it would lead to delayed ischemic necrosis and stricture formation of the ureter. So we carefully dissected from the medial side of the ureter, and any thermal device which was used away from the margin of the ureter, so that it inadvertently do not injure the ureter. And with use of traction and counter traction, we successfully mobilized and lateralized the ureter from the ovarian cyst wall. So this is the last view in which we successfully lateralized the ureter from the ovarian cyst wall without any inadvertent injury to the ureter. And then we handed back the console to the gynecology team for further management. Now I would like to call Dr. Farendra sir to take the case forward.
Thank you so much, Dr. Harsh. First of all, very good morning to respected Emeritus Chairperson, sir, dignitaries on the dais. So here you can see, sir, you have asked about the pain. So when we were discussing about the pain, the first differential was the post-operative adhesions. And as you can see till now, there is extensive adhesions on the left adnexa. Along with that, the cyst is big one, and the adhesions is all around. If we need to do adhesiolysis also, the cystectomy is also one of the planned approach in this particular patient to relieve her pain. So we proceeded with the rest of the dissection.
One should expect so many adhesions.
Yes.
In such cases around the ureter.
Yes.
What you have to think of, where the patient had 2 cesarean sections, remember it. यूरेटर होता है यूट्रस के पास में होता है, बार बार जब ब्लैडर को आप ड्यूरिंग सिजेरियन फ्लैप के नीचे लाते हो तो यूरेटर की एनाटमी डिस्टर्ब हो जाती है.
करेक्ट.
ठीक है ना. और यूरेटर की एनाटमी डिस्टर्ब होने से एडिजेंस और पेन हो सकता है. नॉट दिस सिस्ट मे नॉट बी द कॉज. नाउ वी आर कमिंग क्लोज टू द कॉज. मे बी द इंटरफेरेंस विद द यूरेटर.
Yes.
Or kidneys.
Kidneys, ureters, and bowel movements could be a cyst. So, sir, then
you have to be very, very careful when doing hysterectomy after 2 cesareans. You have to take care of the ureter very well.
Yes. But, sir, in this case, you can see the adhesions was lying at very high up. They were started right below the promontory. And in cesarean, we don't encounter the adhesion at this level. So, the cause could be this of this adhesion is, sir, because the patient have undergone hysterectomy, and nowadays people are doing uterine artery at its origin dissection.
Should I ask you, resident, what are the causes of adhesions and how to prevent adhesions during surgery? नव्या बताओ, जो प्रेजेंट कर रही थी ना, एडिजेंस को कैसे प्रिवेंट करोगी ड्यूरिंग सर्जरी? सबसे इम्पोर्टेंट चीज क्या है? जो मोबाइल नंबर 1 थिंग टू प्रिवेंट एडिजेंस.
So knowing the anatomy and careful dissection.
Hemostasis during surgery सबसे इम्पोर्टेंट है. एकदम bloodless, perfection in the hemostasis. That is number 1. Number 2. What is number 2? यदि आपने रॉ सरफेस छोड़ दिया वहां पे तो क्या करोगे? एडिटिव्स के नाम सुने, इंटरसीड वगैरह यूज करते हैं अपन। पहली चीज तो ये आनी नहीं चाहिए नौबत, आप वहाँ फ्लूइड डालो, ड्राई मत होने दो ऑर्गन्स को। दिस कॉमन सर्जिकल प्रिंसिपल, आई एम नॉट गोइंग टू gynaecology, so those things has to be taken care of, right?
Yes. So as you can see here in the video, a careful blunt and the sharp dissection was proceeded to expose the adnexa to make the cyst removal comfortable and accessible. After extensive dissection done by our GI team and a urological team. Here you can see we are carefully exposing the infundibulopelvic ligament. After understanding that this is a very adherent ovarian cyst and an ovary all around, we took the intra-op decision of removing the ovaries as well in this particular case, because then it become prone for again developing so many adhesions. So here you can see a very thin area of cyst wall can be appreciated, and there is an accidental rupture of the cyst. You can see a very clear fluid which is coming out, and the assistant is helping by doing a gentle suction. So to facilitate further retrieval of this tissue, we deliberately decompress the cyst, because this is in approach in case of minimal access surgeries. So we decompress the cyst to facilitate the further dissection into the plane. And now after, you can see the ureter is nicely lying away. This is the infundibulopelvic ligament which was cauterized and cut. Further dissection was done to separate the ovary from the cyst wall and to the surrounding mesocolon, and very meticulous, sharp and blunt dissection. We could do this one dissection, and finally we proceeded to cut the rest of the adhesion band all around to make this ovary free and to take out the mass completely. You can see a precise current is generated through this advanced instrument, and simultaneously, because when we are operating, this is a very excellent vision you can have on the robotic system. So very precisely we can go to near to the vital organs and perform this surgery safely. Now here the ovary is completely removed and most of the adhesions areas are removed. Contained retrieval is to be done in all the specimen whenever we are taking it out. They should not come in contact with the abdominal wall. The specimen is cut into small pieces, and it is easily removed through the 12 mm port without extending the incision. You can see there was a hemorrhagic cyst was also visible, and this was visible in the MRI as well as a complex thin wall cyst. So we safely complete the retrieval of the cyst. Sir, up.
So if you've already ruptured the cyst, then what is the need of all this? Suppose it was
yes,
a malignant ovarian mass, then the peritoneum is already contaminated.
Correct, sir. Now this bag is for
also it is simple fluid there, watery fluid, so it is benign.
Nothing, which is benign.
What Dr. Saab is saying is right.
And pre-operatively also, sir, we have done extensive workup for this patient.
So oncological principles mean that it has to be removed without rupturing.
Correct, sir.
Otherwise
But
you
this was an
upstage
accidental
the disease
rupture,
by
and
one level.
so we do lot many benign cases as well.
Sir, the preoperative assessment was that of a benign cyst.
Correct.
So the deliberate puncture of the cyst can be defended on one account to facilitate the ease of mobilization and complete removal. So a large cyst can be punctured deliberately so that it becomes easier to dissect and mobilize.
Agreed, sir. Though
So that was a. So many a times when we do, endometriotic cysts or any dense adhesions, you may land up in such spots. You can see there was a very thin cyst wall at that time.
yeah, so if it was not possible to remove without aspirating, then that is different. But
even
if
in
it was
open
possible,
surgery, sir, you can land up in doing accidental rupture of the cyst wall, and this is absolutely the same.
That's fine.
And in fact, I tell you, this is a 10 time of magnification view as you see in a normal conventional surgeries. So you can do much more justice with this advanced minimal access surgical approach.
So the point which we are trying to make from an oncology point of view is that if possible, if you could remove the mass without rupturing, that would have been ideal.
Perfect.
Agreed?
This is completely agreed. Sir.
Another thing, sir, contained retrieval is required to avoid the port
contamination
or port infection, port contamination.
Sir, this is, I understand, sir, as
ये
a
38 years old young
Yes.
patient है.
Yes.
सिस्टर से जैसे हम फॉलिकल एस्पिरेट करते हैं उस तरह का फ्लूइड आया है. इसमें ऐसा कोई मेलिग्नेंसी का चांस नहीं है.
Completely agree, sir, but we cannot sacrifice 97% of the patient. So that's perfectly okay, and we do many benign surgeries as well. Fine. So post-operative period, we can see, sir, on day 1 we mobilize this patient out of the bed within 3 to 4 hours, and sips of clear liquids are around. Thanks to our anesthesia team, do give a intravenous anesthesia in such cases, and the patients are very comfortable post-operatively within few hours. And clear liquids we allow them by the late night. Folies were removed, completely mobilized patient. Sourdough was started on day 2, and third day we discharged the patient in taking a full diet. Because we can see intraoperatively we were not expecting any major event, so we could do this thing. 10th day regular follow-up, suture line was healthy and stitch were removed. Patient came back with a 1 month follow-up, doing all her work, doing well, and resumed her teacher job within 15 days of her surgery. And that is one of the advantages of minimal access surgery. Had it been an open surgery, she would be in the bed for nearly 2 months. So coming to the histopathological report of left adnexal mass, patient reported, the specimen reported to be having a simple serous cyst, as well as that complex was a simple hemorrhagic cyst. And in fact, retrospectively now we can see the imaging which is showing a thin wall cyst, that was a hemorrhagic collection, and that could be the cause of the pain. That could be the various adhesions could be the cause of the pain. If we come back to the review of literature, this is the latest journal which we see. Now we are talking about the minimal access surgery in such cases of extensive adhesion. Previously, you know, a gynecologist may feel that there are extensive adhesion and they may land up in opening these cases and doing laparotomy. Nowadays, with the access of minimal invasive surgeries, a good vision, one can perform a judicious dissection. And this article in Robotic Adherolysis Current Evidence in the Journal of Robotic Surgery shows that they have clinical evidences of robotic surgery. They show that less chances of conversion to open surgery when the surgery is planned in the minimal access way. So here robot is helping us in performing this surgery. This is another article which was published in International Journal of Medical Robotics and Computer Assisted Surgery. They have assessed 98 patients with the pelvic adhesions, and they have taken them for a comparative analysis to between robotic and laparoscopy, and they found that with the robotic system, conversion rate was relatively less. Of course, the other outcomes were not significantly different, but the conversion rate was significantly lower. And the same things were confirmed in various literatures. Coming to the colorectal areas also, sir, in a systemic review, this is a systemic and meta-analysis which was published in 2022, says in terms of conversion related to adhesions shows significant difference in robotic surgical group compared to the laparoscopic group. So even when they encounter adhesion in the pelvic areas, this equipment is helping them to avoid the conversion rate. Regarding the adnexal masses which we were discussing, sir, so adnexal masses, this is a published article requiring re-exploration or re-operation in a women who have undergone hysterectomy. It shows that nearly last 10 years they have assessed 250 of the patient post hysterectomy, and the majority of the adnexal mass turn out to be gynecological origin, turn out to be ovarian origin, and most of them are, more than 80% were benign after doing proper evaluation. So even the literature, you know, supports the approach in minimal access surgeries even in pelvic adhesion where you are suspected. So coming to the few take home message, the previous surgery with a suspected adhesion should not be considered as a contraindication of minimal access surgery. In fact, nowadays we prefer it, we're trying to make them as an indication of performing a minimal access surgery whenever you are suspecting previous multiple surgeries. Robot surgery offers a significant advantage in complex surgery because of her enhanced 3D vision, articulation, precise dissection, and definitely it will reduce the conversion chances from minimal access to the open surgery. Third, the technology is valuable adjunct. It does not replace our surgical judgment. Success in complex cases depend upon the appropriate patient selection, anticipation in anticipation of inappropriate challenges, and knowledge of pelvic anatomy. As you can see, we were not expecting much adhesion around the ureter, and intraoperatively we call the urologist to help us out. We were expecting bowel adhesions because ureter passes very near to this all adnexal masses. So definitely this case demonstrates that even in a complex adnexal masses, dense bowel and ureteric adhesion can be managed successfully using a planned, multidisciplinary, minimal invasive approach. So thank you so much for everything. I would like to acknowledge and extend my heartfelt thanks to the Almighty, patient or family, university leadership, hospital administration for providing platform and infrastructure, Department of Urology, Department of GI Surgery, Department of Radiodiagnosis, Department of Anesthesia and CCR Review Committee.